Hello, everyone, and warm welcome to today's edition of Pathcast. Hope you all are staying safe. Today is July 10, 2020. I am Rifat Mannan in Philadelphia, and I am remotely joined by my very good friend Emilio Madrigal, who is in Boston. Today, we are excited to welcome back Dr. Roberto Garcia for the third lecture in the Bone Pathology lecture series. Dr. Garcia is Associate Professor of Pathology at the Hospital for Special Surgery in New York. The title of his talk today is Miscellaneous Bone Tumors. As always, please feel free to post your questions and comments on both YouTube and Facebook chat windows, and Dr. Garcia will answer them towards the end of the session. And today, I also pay tribute to Dr. Juan Rosai, who passed away recently, and the pathology community has lost one of its pioneers who influenced so many pathologists across the world. We pay our sincere tribute to Dr. Rosai. With that, pass over the microphone to Dr. Garcia. Thank you for joining us. Over to you now.
Thank you, Rifat, and good morning, everyone. Very sorry to hear about Dr. Rosai. We are going to be talking today about miscellaneous bone tumors. This is the third part of the three-lecture series. We talk about bone-forming tumors, cartilage-forming tumors, and today we're going to be discussing all the tumors that do not really form any particular type of matrix. This is my disclosure slide, and we're going to be talking about Ewing-sarcoma, Langerhans cell histiocytosis, Adamantinoma, giant cell lesions, giant cell tumor, and giant cell lesion of small bones, and then fibrous tumors, benign and malignant. So we start with Ewing-sarcoma. It's a primary osseous and soft tissue neoplasm of small, round, primitive-looking cells, which are relatively uniform and have no evidence of matrix production, no bone, no cartilage. If you do see any formation of cartilage or bone in a Ewing-sarcoma, it probably may be related to a pathological fracture, and that must be components of a fracture count. This particular tumor carries in about 90% of the cases a specific chromosomal translocation between chromosomes 11 and 22, which leads to a gene fusion, EWSR1 and FLY1, with the resulting expression of a protein, which is membranous, detected by the antibody CD99, which is a protein that is known to act as a transcription factor for cell proliferation and also has anti-apoptotic properties. Now, it is known that Ewing-sarcoma has a great variety of alternate gene rearrangements, many of which include EWSR1 with other members of the ETS family, as well as members of non-ETS. And also, there are a couple of rearrangements and translocations that really do not include EWSR1, like FUS with FEV and ERG. Lately, there have been two entities that are pretty distinct, but with similar characteristics to Ewing-sarcoma. These two encompass mainly CHICDOX4 and BCOR-CCNB3 rearranged round cell sarcomas. And these two entities really have very specific and distinct clinical pathological characteristics that actually deserve a separate category, even though they usually discuss together with Ewing-sarcoma. So in a lot of circumstances, they are referred to as Ewing-sarcoma-like round cell tumors. Ewing tumor, Ewing-sarcoma, is a tumor of young life. Most of the cases occur in the second decade, but they can occur in the first decade, and actually are distributed along the entire span of life. I have diagnosed cases in patients as old as 70. So even though very rare in older adults, it can occur. And And it's important to remember that Ewing sarcoma can occur as a soft tissue standalone tumor without any evidence of skeletal involvement. The most common location for Ewing sarcoma is the diaphysis of the femur. It has been described also in many other locations like the pelvic bones, the ribs, the humerus and tibia, and practically anywhere else, just like osteosarcoma. The most common location would be the midshaft, the long bone, and the femur would be a preferred site. The tumor is more common in males, and characteristically, it appears as a lucency within the bone. Most of the times, it doesn't have any type of perilesional sclerosis or any internal sclerosis that indicate matrix production. And one of the characteristic features is the formation of a sort of like an lamellated onion skin-like pattern of periosteal reaction. It is characteristic but not pathognomonic of this condition, because this same pattern may be seen in other conditions like Langerhans histiocytosis and even in osteomyelitis. The histomorphological characteristics of Ewing sarcoma are monotonous proliferation of small round blue cells with relatively uniform nuclei, scant cytoplasm that can be pale pink to clear, and it is not uncommon to see areas of geographic necrosis and scattered mitotic activity. This is another example of a Ewing sarcoma where you see significant amount of periosteal reaction. You almost see a little bit of a Cutman triangle almost forming right here. And one thing that is seen on this X-ray is that there's a shadow of a soft tissue mass. So it's not uncommon to see Ewing sarcoma that has disseminated already through the medullary cavity to percolate through the cortex and invade into the soft tissue, forming a large soft tissue mass, which can be better appreciated in other modalities like CT and MRI. Here we see a gross specimen where we can see the intramedullary component of the tumor is a fleshy nodular mass with areas of hemorrhage and maybe focal cystic change, pathological fracture, and we can see the large soft tissue mass, that soft tissue component that many times cannot be clearly appreciated on the plain film. The histomorphology, again, is that of a monotonous proliferation of small round blue cells, relatively uniform, scattered mitosis, and nucleoli that are considered to be inconspicuous. They're very small. There's really no significant amount of matrix production by the tumor. And here we see CT and MRI showing us soft tissue extension of the tumor. MRI is much better because you can see how much involvement of the medullary cavity you have, as well as the associated soft tissue mass, which is appreciated better here on a fluid-sensitive sequence. This is one example of a Ewing sarcoma where we see a tremendous permeation of the intertrabecular spaces, and you also see that the tumor cells invade into the haversian spaces. So these small round cells can really percolate through a thick cortex and gain easy access to the extraosseous compartment. In this one in particular, we see significant amount of fibrosis in the marrow, which is not really very often common. You will normally see a sea of small round blue cells occupying almost the entire intertrabecular compartment. And we can see here the appreciated morphology of the small round blue cells. Scattered lymphocytes may be seen in between the tumor cells. And here we see the classic immunohistochemical profile of Ewing sarcoma. They have diffuse and strong membranous staining by CD99, as well as nuclear staining, robust nuclear staining with Fly1. Another marker that is pretty sensitive but non-specific is NKX 2.2. It is very useful. Unfortunately, like CD99, NKX 2.2 has been detected in other tumors that are not Ewing sarcoma. So, when you use it, you have to be careful. as well as you are with the CD99. The differential diagnosis of Ewing sarcoma is pretty broad because a lot of tumors can have small round blue cell morphology, but I'm going to just mention a few of the most important ones. Lymphoblastic lymphoma is a tumor that occurs in children. It can be CD99 positive and negative for leukocyte common antigen. Interestingly, a good tool to diagnose it is TDT, which is consistently positive in this tumor. And of course, there are no rearrangements of the EWSR1. Metastatic neuroblastoma, another tumor of young children, is consistently negative. It's also a tumor of round cells, and it's negative for CD99, negative for EWSR1 rearrangements. Characteristically, they have loss of 1P or 11Q. Rhabdomyosarcoma can occur in bone, but as you know, Ewing sarcoma also occurs in soft tissue, so it could enter the differential diagnosis. You normally look for rhabdoid cells, and sometimes you can find them. So we have markers like desmin, myogenin, and MyoD1, which are good for skeletal muscle. And of course, rearrangement of EWSR1 are negative in rhabdomyosarcoma. Mesenchymal chondrosarcoma, primary bone tumor, characteristically shows areas of chondroid matrix formation. It is positive for CD99, but is negative for EWSR1 gene rearrangement, and characteristically shows the gene fusion HEY1 and COA2. So that's a good tool to make the distinction. And finally, small cell osteosarcoma, which is characterized by osteoid matrix, which is sometimes very focal and hard to find. And the tumor cells are strongly positive for SAB-B2. Absolutely not specific, but very helpful in tumors of osteoblastic lineage. And of course, EWSR1 rearrangements are not detected. It is important to remember, because nowadays EWSR1 rearrangement is tested by FISH, where only a probe for this gene is used, that it is not diagnostic of Ewing sarcoma. It may be seen in a great variety of other tumors of bone and soft tissue, which includes desmoplastic small round cell tumor, exoskeletal myxoid chondrosarcoma, myxoid liposarcoma, clear cell sarcoma, and rheumatoid fibrous histiocytoma, and myoepithelial tumors of bone and soft tissue, benign and malignant. So be aware of that EWSR1 gene rearrangement has to be interpreted carefully in the appropriate clinical and histopathological context. Multi-agent chemotherapy, neoadjuvant chemotherapy with or without radiation, and limb-sparing surgical resection is the treatment of choice for Ewing sarcoma. With this modality, the 5-year survival rate has been remarkably improved, up to 74%, in cases that present without metastasis. Metastatic, the presence of pulmonary metastasis actually has an adverse impact on survival. Patients with pulmonary metastasis will have only about 30% survival. Histopathological assessment of chemotherapy effect in Ewing sarcoma has prognostic value. So we do, similarly to with osteosarcoma, we do tumor mapping of on the resection specimen, and to evaluate the effect of chemotherapy. And this is one photograph of one case that had an excellent chemotherapy response. We see the bone trabeculae that have some remodeling and some reactive bone around them, but essentially the marrow spaces, which used to be occupied by tumor, are now basically a sea of nothingness. All you see is just this acellular fibrotic stroma with some myxoid areas as well. 90% tumor necrosis is what is expected to find. More than 90% tumor necrosis is what is expected to be found in patients with resection after chemotherapy. So a few points about Ewing-like round cell sarcomas, the so-called CHICDUX4 and BCOR-CCND3 tumors. These tumors have very specific similarities and differences with Ewing sarcoma and among themselves. Let's start by saying that most of CHICDOX4 tumors occur in young adults. They really have a similar sex preference. BCOR tumors usually occur in children and young males. So they have a tremendous predilection for the male gender. CHICDOX4 tumors are usually in the soft tissue, usually exoskeletal, versus BCORs that usually arise in bone. CHICDOX4 has an aggressive course with early metastases, usually to the lungs, liver, bones, and even lymph nodes, versus BCOR, which has a survival that is similar to conventional Ewing sarcoma. CHICDOX4 tumors have more cell variation, more nuclear variation. You can see round to ovoid cells with prominent nucleoli, abundant cytoplasm, extensive necrosis can be seen, and numerous mitosis, which you normally don't see in a classic Ewing's. BCORs have round cell areas that frequently merge with spindle cells. Spindle cell areas are very common. And you may see also pleomorphic cells and focal osteoid formation in BCOR tumors. Both may present variable areas of myxoid change, and they are both positive in a variable way with CD99, which can vary from patchy, weak, to focal, and even sometimes completely negative. One characteristic feature of CHICDOX4 tumors is that there's a frequent positivity for WT1, which is actually very helpful in the diagnosis of this tumor. This is an aberrant expression, has nothing to do with any particular mutation. BCOR tumors can be easily diagnosed by staining with the appropriate markers for those genes. The synovial sarcoma marker TLE1, it is consistently positive, very strongly positive in BCOR tumors, and it may be also positive in CHICDOX4. So that again makes some of these markers not specific, and they have to be aware of that, because you can very easily fall in the trap of calling something fully differentiated synovial sarcoma if you don't do the mutational analysis. Finally, CHICDOX4 tumors can be positive immunohistochemically for ERK and FLI1, and BCORs are positive for BCL2, c-KIT, and importantly, they can be positive for SADB2, a marker that is indicative of osteoblastic lineage. So in a case like this, if you only go by immunohistochemistry, you find some spindle cell areas, focal osteoid formation, and SADB2 positivity. You may fall into the trap of calling this a small cell osteosarcoma. So it is important to always go for the genetic testing. The treatment of BCOR and CCNB3 and as well as CHICDOX4 tumors so far is with the same protocols as for Ewing sarcoma, and the responses are variable. Here we have an example of a case of a man in his 60s who had a history of squamous cell carcinoma of the upper respiratory tract that on surveillance PET-CT was found to have a mass in the proximal thigh. It was deep-seated, and it was considered to be a probable metastasis. And on MRI, we see that the tumor appeared to be low signal on T1 and bright signal on water-sensitive sequences. And the biopsy showed a tumor that had a small round cell morphology. There is variability in the size and shape of the nuclei. Some of the nuclei had nucleoli. There were extensive areas of necrosis and a very high mitotic rate. So initially, the workup for lymphoma turned out to be negative, and so of course for carcinoma, which was exactly what they were trying to rule out. In the first round of immunohistochemical staining, the tumor, in the second round, the tumor turned out to be positive for CD99, FLI1, and also TLE1. In the meantime, the tumor was sent for EWSR1 gene rearrangement, which was reported as negative. Subsequently, we ordered WT1, which turned out to be positive. And after that, it was sent for CHICDOX4 studies, and it was found to be fused As we see here, the green and the red signals appear fused over here. So it was positive for cheek ducts for rearrangement. This was a cheek ducts for brown cell sarcoma occurring in an older patient. And essentially, the moral of this case is that WT1 is your wild card in the diagnosis of these tumors. Every time you see a Ewing sarcoma that is atypical, meaning that it doesn't have all the classic features of Ewing sarcoma, do a WT1. If it's positive, it is likely to be a cheek ducts for rearranged round cell sarcoma. Moving on to another entity, we're going to talk about eosinophilic granuloma, which is what most bone pathologists refer to this lesion as, but the adequate term should be Langerhans cell histiocytosis. This is a proliferation of Langerhans histiocytes, and they're usually accompanied by tons of eosinophils, as well as lymphocytes and plasma cells, and many times neutrophils as well. This disease has been viewed as a reactive process, but lately X chromosome inactivation studies have suggested or supported that this is a clonal proliferation. The lesion may be extraskeletal and multivisceral, and in most cases occur in the first decade of life. So young children are most commonly affected, and the great majority in the first decade. It is more common in males. The lesions may be solitary or multifocal, as seen here, the skull, which is one of the most common sites where these lesions occur, and may or may not necessarily combine with visceral lesions. There are two main clinical syndromes that are well characterized. One is the so-called Hand-Schuller-Christian disease, where multiple bone lesions are associated with diabetes insipidus and exophthalmos, and the usually fatal letter C with disease, which is a very systemic, rapidly progressive disease. But in our practice, what we mostly see are the solitary lesions in bone that are known as eosinophilic granuloma. This is a very distinct entity from what is seen in the lungs of smokers, which is another type of eosinophil, very similar histologically, but it's completely distinct. Langerhans cells have immunological functions that are not clearly delineated as of now. And immunohistochemically, they are positive for S100, CD1A, and Langerhans, which are actually the two markers that are diagnostic in this condition. Of course, they may stain positive for other histiocytic markers like CD68 and CD163, but most importantly, these three are the ones that will help you in establishing the diagnosis. Langerhans cell histiocytosis have BRAF mutations in about 60% of the cases, which constitutes an interesting therapeutic target. Eosinophilic granuloma is a disease of children and young adults, mostly the first decade, second decades of life, and then they become the incidence declines as patients go into adulthood. Most commonly, they affect the mid-shaft of the femur, just like Ewing sarcoma. They can also occur in the skull and other long bones. Axial skeleton includes ribs, scapula, spine, and pelvis. Radiographically, Langerhans histiocytosis also shows a significant onion skin periosteal reaction, just like Ewing sarcoma, and also like you may see also in osteomyelitis. So these three entities always go together in the radiological differential diagnosis. Here's an MRI where we can see clearly there is a mass in the mid-shaft of the femur. Another case, which is more subtle, we almost practically see just a tiny little area of lucency here and a very prominent onion skin pattern of periosteal reaction. So again, differential diagnosis is osteomyelitis, Ewing's, Langerhans histiocytosis. The mass can be seen in MRI, and the histology is that of a proliferation of large histiocytes with abundant pale cytoplasm. The nuclei usually show folds or, let's say, grooves that impart sort of a coffee bean appearance, and there may be variable background reactive inflammatory infiltrate. Multinucleated osteoclastite giant cells may be seen, and here's a stain with CD1A, which is the most used stain in clinical practice for the diagnosis of this condition, as well as Langerhans. Eosinophilic granuloma has a usually accumulation of histiocytes that form ill-defined granulomatous conglomerates and surrounded by lymphocytes, plasma cells, and eosinophils, as we can see here. Those histiocytes have ample amount of amphiphilic to pale basophilic cytoplasm, and the nuclei are variable. Sometimes they may appear multinucleated, but most of the times the single nucleus has a longitudinal grooves or folds that impart that sort of coffee bean appearance. In the past, Langerhans histiocytosis used to be diagnosed or confirmed by electron microscopy by the finding of these interesting intracytoplasmic inclusions that have a rod shape or racket shape that are known as Fibrous granules, and they're characteristic of Langerhans cells. Here we have a beautiful nuclear fold or groove in the middle of the histiocyte. So the differential diagnosis includes osteomyelitis and Ewing-sarcoma. Sometimes I have seen cases where there are practically no eosinophils and a multitude of neutrophils, in which case one has to be cautious and not diagnosing it as an osteomyelitis. It is important to look for the presence of Langerhans histiocytes, and if you have it available, stain with CD1A or Langerhans. Ewing-sarcoma, of course, enters the differential diagnosis clinically, but the histomorphology is completely different. And I also probably will include here a very rare disease that can affect bone and soft tissue, which is Rosai-Dorfman disease, where the histiocytes will be positive for S100 or negative for CD1A and Langerhans, and they will show a phenomenon of lymphophagocytosis, also known referred to as enteropoiesis. They usually have this background reactive inflammatory infiltrate with lymphocytes, plasma cells, and eosinophils. But the histiocytes are larger, pale, and they show lymphophagocytosis. And again, positive for S100, negative for CD1A and Langerhans. The treatment of Langerhans histiocytosis is with curettage or intralesional steroid injection. Recurrences are rare, and there's always a potential for developing additional lesions, and patients with multiple lesions may have an increased risk of developing visceral involvement. The next entity we want to discuss is Adamantinoma. This is a primary osseous neoplasm of low-grade malignancy, which shows a marked predilation for the mid-shaft of the tibia. It is considered to be low-grade because it's slow-growing and it doesn't really have high-grade features histologically. However, these tumors may metastasize. They have a significant metastatic potential. So that's one thing that needs to be taken into consideration. Adamantinoma is a disease of adults, mostly occurs in the third decade, but it has been described even in older patients. Peak incidence in between ages 25 and 35, and it appears to have almost equal gender distribution. May present with pain, swelling, and occasional pathological fracture. And the lesions have a tremendous predilection for the mid-shaft of the tibia. Most of the cases occur there. Same location for osteofibrous dysplasia. The only difference is that osteofibrous dysplasia is a disease of children. The fibula is involved in about 10% of the cases, and it's not uncommon to see synchronous involvement of both the tibia and the fibula. Adamantinoma may be multifocal. So, again, tremendous predilection for the mid-shaft of the tibia. Sometimes it may occur in the metaphysis. The lesions have a very peculiar appearance on radiograph. They have multiple lucencies surrounded by sclerosis, which impart a bubbly appearance to the tumor. It appears that the lesion started in the cortex or involves the cortex predominantly, but then also secondarily invades into the medullary cavity, and it is not uncommon to see it coming out into the soft tissue which is distinct from what you see with osteofibrous dysplasia. Here we also see that the lesion is multifocal. Cortical destruction and invasion of the soft tissue is commonly seen, and it is important to mention that there is a subtype of Adamantinoma, which is not the classic one, that tends to occur in the same age group as osteofibrous dysplasia. This is called differentiated Adamantinoma or osteofibrous dysplasia-like Adamantinoma. We're going to see an example of that in a little while. Histologically, Adamantinomas are biphasic tumors. We have epithelial clusters, nests, glands, tubules embedded in a moderately cellular fibrosarcoma. They may have areas of bone formation with irregular trabeculi of woven bone, similar to what you may see in an osteofibrous dysplasia. But clearly, you see that the epithelial differentiation is quite profuse. There's a tendency to have nests that have a basaloid appearance. There are darker cells surrounding the big nest. And sometimes all you see is just small clusters, tubules. There are basically four patterns described. There's one basaloid, spindle type, and also squamoid or squamous appearance, and tubular as well. So given this histomorphology, a metastatic carcinoma needs to be excluded. Most of these lesions occur in young adults, but which is an age where carcinomas are not that common, but it's always something that needs to be taken into consideration. And also osteofibrous dysplasia because of the location. But remember, this is a lesion of young children. The subtype that is called differentiated Adamantinoma or osteofibrous dysplasia-like Adamantinoma is a tumor that is exclusively intracortical. It occurs in the same age of osteofibrous dysplasia, and histologically, the difference will be that the epithelial clusters will be clearly visualized on H&E. The rest of the histomorphology is identical to osteofibrous dysplasia. You have a moderately cellular fibrosarcoma with irregular trabeculi of woven bone that are lined by osteoblasts, and that is clearly seen. But then you can identify the epithelial component clearly on H&E. In an osteofibrous dysplasia, you would have to do an immunohistochemical stain for keratin in order to find isolated single cells. So this is the main distinction. If you do a cytokeratin stain on an intracortical lesion and you see only isolated cells, you can clearly and confidently call it osteofibrous dysplasia. But if you do see clusters, or you can identify them on H&E, then you have to call it differentiated Adamantinoma. These tumors have a very good prognosis and they do not metastasize. And they may probably represent an intermediate stage between osteofibrous dysplasia and classic Adamantinoma. Adamantinoma is positive for mesenchymal marker vimentin, but also a variety of keratins, including A1, A3, CK5, CK19, among others. EMA is also positive, as well as P63, and interestingly, also podoplanning will be positive, B240 on Adamantinoma. CK8 and 18 are negative, so CAM5.2 will be negative, and this will be good for the differential diagnosis. Adamantinoma shows trisomies or extra copies of chromosomes 7, 8, 12, 19, and 21. The first three, 7, 8, and 12, can also, these trisomies can also be seen in osteofibrous dysplasia, suggesting that there is some genetic link between the two conditions. This is an example of a case that was sent to me in consultation on a patient in his early 20s. He had a very bubbly looking lesion in the midshaft of the ulna, which happens to be the third bone that is most commonly affected. It's rare, but if you have it outside of the tibia and fibula, the ulna will be the next runner-up. And this lesion shows an intramedullary lesion that has an expansion of the mid-shaft of the bone, multiple lytic lesions surrounded by sclerosis, and on biopsy, it showed a tumor that had a lot of irregular woven bone trabecula in a fibrous stroma, but in between you see all these epithelial clusters that show clear squamous differentiation, including pseudohorn cysts and even keratin pearls. So, of course, this was a patient in his 20s. He had no history of cancer. This is not a metastatic squamous cell carcinoma. It is an adamantinoma with squamous differentiation in the ulna. The treatment is complete excision or unblocked dissection. The recurrence rate is almost up to a third of the cases. Metastatic rate is between 10 and 30%, depending on the series, and it happens to bone, lungs, lymph nodes, liver, and brain. They may occur very late, so even decades after the initial resection, so long-term surveillance is necessary in these patients. Moving on to Janssen cell lesions, we're going to discuss Janssen cell tumor of bone, the prototype Janssen cell lesion of bone. It is a benign, locally aggressive neoplasm that is characterized by a large number of multinucleated osteoclast-type giant cells in a sea of mononuclear cells that are the actual neoplastic component of the tumor. The giant cells are reactive. This tumor used to be referred to as a malignancy because it is locally aggressive, and in about 2% of the cases, there can be pulmonary metastases. But these metastases are usually indolent and usually do not cause patient death. So based on that, the tumor was reclassified as benign locally aggressive. It comprises about 5% of all primary bone tumors, and the diagnosis requires very careful clinical radiological correlation, and now even immunohistochemical and genetic correlation, because there's a ton of tumors that can have a lot of osteoclast-type giant cells. Many times, in the majority of the cases, they are reactive, but they can mimic a giant cell tumor. Just to name a few, we can mention non-ossifying fibroma, aneurysmal bone cyst, and there are even osteosarcomas or undifferentiated pleomorphic sarcomas that have an overabundance of giant cells, and even carcinomas that have a lot of giant cells. The mononuclear cells are the neoplastic population, and like I mentioned, and the tumor giant cells are reactive. Giant cell tumor of bone is a disease of mature patients, so most of them occur in the second and third decades of life. Patients that have already a closed epiphyseal growth plate. And the great majority of them will occur around the knee, in the distal femur, proximal tibia. They may also be seen in the distal radius, very commonly proximal humerus, and in the axial skeleton, most commonly the pelvis and sacrum, and also very rarely in the vertebral bodies. Very rare in the small bones of the hands and feet, but they do occur. Giant cell tumor has a slight predilection for females, about 1.5 more commonly in females, and the lesions are predominantly lytic with a very narrow zone of transition, meaning that there's a sharp circumscription of the lesion. You can really see where the lesion stops, and rarely you see a little bit of sclerosis, but it's usually not very prominent. The lesion characteristically occupies the epiphysis and it extends into the metaphysis, so it occupies both compartments. Most of the times, chondroblastomas will occupy only the epiphysis with some extension into the metaphysis, but giant cell tumors do expand all the way into the metaphysis. The difference is that chondroblastomas most of the times occur in individuals that are skeletally immature, so the growth plates will still be open. The lesions sometimes can break through the cortex and invade into the soft tissue. At times, they can appear very aggressive, and especially if they have secondary aneurysmal bone cysts, they may appear much more aggressive than they really are. In pathological fracture may be seen in about 10% of the cases, but maybe more. and may be quite destructive and radiological worrisome. The gross appearance of giant cell tumor bone is that of a very hemorrhagic looking tumor with focal cystic change. They have this mahogany brown appearance. Again, areas of hemorrhage and hemosiderin pigment impart a brown appearance. They may also have areas of infarction or necrosis, which is nothing indicative of malignancy. Here's a ray amputation of a giant cell tumor that occupied basically the proximal phalanx and also the metacarpal bone, so they can basically invade outside of the confines of the original bone into other bones. Giant cell tumor bone is characterized by a evenly distributed osteoclast-type giant cells and background mononuclear population of cells that have somewhat histiocytic-like appearance. Some of the cells may be spindled as well, and it is also accompanied by variable degrees of inflammation, lymphocytes, and occasionally you can see a plasma cell. The giant cells of giant cell tumor bone can be quite large. Many times you can see cells that contain more than 30 nuclei in one section. Which is in contrast with the size of a normal osteoclast, which only will have about 8 to 12 nuclei. There may be areas of spindle cell or almost like a fibrohistiocytic appearance in giant cell tumor with spindle cells that are arranged in a fascicular to storiform pattern associated to hemosiderin deposition, and even a significant amount of sarcoma cells or foam cells, lipidized macrophages within the lesion. If you take a biopsy from an area like this, you may think about something like a fibrohistiocytic tumor or fibrous histiocytoma. Here's a closer view. It is emphasized in many books that the nuclei of the giant cells and the mononuclear cells are similar. There is actually a dual population of cells in the mononuclear component. One would be the actual tumor cell, which has a more of an osteoblastic phenotype, and you have also another population which is a precursor, kind of like a macrophage monocyte precursor that is the pre-osteoclastic cell, which eventually will differentiate into a mature multinucleated osteoclast-like giant cell. So, like I mentioned before, that osteoblastic or pre-osteoblastic phenotype of giant cell tumor is characterized by positivity for many markers like osteocalcin, osteonectin, type 1 collagen, which are characteristic of osteoblasts. Rank ligand is an important positive marker in giant cell tumor bone, because this ligand is present in the surface of the pre-osteoblast and actually is the one that induces osteoclastogenesis. So by an excess production of this ligand is how all these multinucleated giant cells develop, and they're terminal. They're not going to divide or multiply. So they're reactive as a consequence of the excess production of rank ligand by the tumor cells. They may also be positive for P63, which once was thought to be a promising marker, but it can also be seen in chondroblastoma and many other tumor cells. Interestingly, SADB2 is strongly positive in the mononuclear cells, proving that they do have a osteoblastic lineage. And lately, it has been described that giant cell tumors of bone in about 90% of the cases show mutations of the histone-related protein H3F3A, which is detected by an antibody called G34W, and it is extremely useful in the diagnosis of giant cell tumor because there's a strong and robust nuclear staining of the mononuclear cells with this marker. Giant cell tumor bone also has IDH2 mutation similar to classic cartilaginous tumors of bone, like in chondroma and classic chondrosarcoma. Like mentioned before, giant cell tumors may give rise to indolent pulmonary metastases that are amenable to resection when possible and may regress spontaneously. And there's really no way to predict histologically or clinically how when the tumor will metastasize. Even the presence of vascular invasion on histological sections, which is not uncommon, does not really correlate with increased incidence of metastasis. So finding metastasis from giant cell tumor bone is not really a nominal sign. Actually, it does happen, and usually does not cause patient death. Of course, the differential diagnosis is pretty broad. Again, I'm going to try to go over the most important ones. Giant cell tumors of bone need to be differentiated or distinguished from giant cell lesions of small bones, ex-giant cell reparative granuloma. This is a lesion that exclusively occurs in the small bones of the hands and feet, where giant cell tumors are rare, but they do occur as well. And these lesions are now related also to ABC, which is also included in differential diagnosis, solid ABC, which is now within the spectrum of lesions that are USP6 gene rearranged. So rearrangement of USP6 is helpful in distinguishing these lesions from giant cell tumor, and of course the antibody G34W will be positive in giant cell tumor and not in these lesions. Another entity that needs to be distinguished from giant cell tumor bone is brown tumor of hyperparathyroidism. This looks more like a giant cell reparative granuloma in terms of the distribution of the giant cells. They usually are not evenly distributed. The same with these two lesions. The distribution of the giant cells in giant cell tumor bone is so diffuse and so uniform that almost on every section that you submit, you're going to see the same thing. But in these lesions, there's a tendency for the giant cells to cluster around areas of hemorrhage. Brown tumors of hyperparathyroidism are associated to abnormalities of parathyroid hormone, calcium, and phosphorus, which is useful and can be clinically confirmed. And they're negative for G34W. Chondroblastoma is probably one of the difficult differential diagnoses because both lesions occur in the epiphysis of long bones. These chondroblastomas tend to have chondroid matrix production, usually very focal, and they occur in skeletally immature patients, in young patients. But these, in both of them have histone mutations, H3F3A and B. But chondroblastomas are strongly positive for the antibody K36M. So that would be a way of distinguishing the two. Non-ossifying fibroma and benign fibrous histiocytoma are lesions that tend to occur in the metaphysis of the long bones, but very rarely will involve the epiphysis. And like I said before, the distribution of the giant cells in these other lesions that are not giant cell tumor is usually non-uniform, clustering around areas of hemorrhage. And of course, they will be negative for G34W. Giant cell-rich osteosarcoma is a rare type of osteosarcoma that has an overabundance of osteoclast-type giant cells, but characteristically has osteoid matrix production, and there will be clear and definitive nuclear anaplasia, mitotic activity, and necrosis, which will help distinguish it from a giant cell tumor. Finally, metastatic carcinomas from the GU, tract, pancreas, breast, with an overabundance of osteoclast-type giant cells have been described and need to be ruled out in the appropriate clinical context. So radiographic appearance will be very helpful because it is so characteristic for giant cell tumor that it will be unlikely for that to be a metastatic carcinoma, but if you need to, you can resort to immunohistochemistry and of course clinical survey looking for a primary. Telomeric associations are characteristic but not pathognomonic of giant cell tumor of bones. You can see chromosomes that are bound by the telomeres, and it can be seen also in giant cell tumor of soft tissue, which is a very interesting phenomenon. But the giant cell tumors of soft tissue are not positive for G34W. The treatment and prognosis of giant cell tumor of bone is usually by curettage and bone packing, which is not really the optimal way of treating them, but this is the most popular one. Usually with or without adjuvant, most of the times liquid nitrogen is used to basically as an adjuvant to the curettage to sort of kill all the surviving tumor cells in the cavity. Unblocked excision is a lot more effective. Cryosurgery, so the results are similar to curettage, and the recurrence rate is up to 30 to 40%. So it's quite high. It usually occurs between 2 to 5 years. But still, most of the cases are treated with curettage and bone packing. Lately, there's an antibody against prime ligand, which is called denosumab, which is very effective at treating giant cell tumors, but it cannot be used as a definitive therapy. Anyway, the tumor has to be removed afterwards. This is a patient that presented with a radial tumor, which occupied the epiphysis and metaphysis, and he had somewhat a very narrow zone of transition and a little bit of expansion of the bone, and essentially on biopsy showed the classic features of a giant cell tumor of bone. It was treated with denosumab for about 2 to 3 months, and we saw the changes radiographically. The tumor became sclerotic inside, and the histological counterpart to that is that there is total disappearance of the giant cells. The mononuclear cells become attenuated and basically spindled and trapped between all these seams of woven bone or osteoid with focal mineralization. So what happens is that somehow denosumab, by inhibiting the osteoclastogenesis, actually makes the osteoclast disappear, and the mononuclear cells will produce bone and replace all of the stroma with all these woven bone. So this is the histological change that characterizes denosumab-treated giant cell tumor of bone. So obviously these lesions are curated or removed after the treatment has finished, but essentially will probably reduce the size and make it much easier for diagnosis. For treatment. Denosumab has also been used for untreatable disease or tumors that are in a very difficult location, as well as tumors that have recurred multiple times, and then more operation is really not feasible. Malignancy in giant cell tumor of bone is very rare, but it has been described. It used to occur more commonly when giant cell tumors used to be radiated. They're not radiated anymore, and it can occur de novo. And usually the lesions occur in the same locations as giant cell tumor of bone, but usually show a rather more aggressive appearance on the radiograph, less well-defined margin. And on histology, you see frank nuclear anaplasia in the mononuclear cells. The giant cells will still remain with a benign appearance, but you see very large vesicular nuclei, prominent nucleoli, tons of mitosis, necrosis, and sometimes the tumor may have the appearance of an osteosarcoma or an undifferentiated pleomorphic sarcoma. Giant cell lesion of small bones, ex-giant cell reparative granuloma, is a benign lytic lesion of the small bones of the hands and feet. The phalanges and metacarpals can be involved, usually involve the metaphysis and the diaphysis, and they're quite expansile lesions. That is because the bones of the small bones of the hands and feet are not really very strong bones, so it's very easy for a lesion to expand over here. They may appear radiographically aggressive, and the lesions are histologically similar to a giant cell granuloma of the mandible and maxilla, and also very similar to brown tumor of hyperparathyroidism. We're going to see images of that in a while. The main differential diagnosis is with giant cell tumor, which is not so common but does occur in this location. And the treatment is with curettage and bone grafting. Prognosis is excellent. Recurrence can be up to 30%. The lesion is, like I said before, common in small bones of the hands and feet. The ones that occur in the gnathic bones used to be lumped together with it, but lately there have been studies that have found that these lesions are USB6 rearranged in about 90% of the cases. That is the small bones of the hands and feet, but not the gnathic bones. So that basically has led to separation of these lesions, and now These small bone lesions are considered to be more within the spectrum of aneurysmal bone cyst, which is a USB6-rearranged tumor. Very common in young adults, between 10 and 25, but they can occur at any age. The appearance of Janssen hepatic granuloma is that of a cytologically bland, but can be quite cellular spindle cell proliferation with a fascicular to storiform pattern with areas of hemorrhage where there's a tendency for the osteoclast giant cells to cluster. They're not really evenly distributed like you see in a giant cell tumor. And you may see focal areas of reactive bone. And here we have a closer view of an area with hemorrhage and clustering of the giant cells. Notice that the spindle cells have very bland, plump nuclei, the appearance of a fibroblast or a myofibroblast. Occurrences can occur in up to 50% of the cases. Moving on to fibrous tumors, we're going to talk about metaphyseal fibrous defect and non-ossifying fibroma. These lesions are lesions of bland spindle cells with a multitude of osteoclast giant cells, as well as histiocytes, foamy histiocytes, and hemosiderin pigment. They can occur within the cortex, and that's when they are called metaphyseal fibrous defect, or they can occur in the medullary cavity and expand into the medullary cavity, and that's when they're called non-ossifying fibroma. Metaphyseal fibrous defect usually occurs at the area of insertion of a tendon or a ligament. And the pathogenesis is not known, but may be related to trauma. They may be solitary or multiple. And non-ossifying fibroma is associated with neurofibromatosis in about 5% of the cases. In the Jaffe-Campanachi syndrome, multiple non-ossifying fibromas are associated to pigmented skin lesions, café au lait spots, and probably there is a combination of multiple non-ossifying fibromas, café au lait spots, and neurofibromatosis. The lesions are asymptomatic and usually found incidentally when an X-ray is performed for other reasons, usually when there is a trauma. Non-ossifying fibroma is a tumor of children, usually seen, the peak incidence is in the second decade, but its true incidence is really not known because, as we say, many of these lesions are asymptomatic, so a lot of them will resolve spontaneously and will never be diagnosed. The lesions are more common in the distal femur, proximal tibia, distal tibia. They can occur also in the proximal femur and the proximal humerus. And they usually present, in the case of metaphyseal fibrous defect, as an intracortical lucency in the area of a tendinous insertion, or as an intramedullary cortical-based eccentric lesion with scalloped margins and perilesional sclerosis. This is so characteristic of non-ossifying fibroma that you really don't need a biopsy to confirm the diagnosis. Because many of these lesions are asymptomatic and they may resolve spontaneously, they usually are just followed up radiographically and no procedure is performed on these patients. It is important to remember that this is a lesion of young individuals, so the growth plates most of the times will be open. Here we have another example. It's a cortical-based or cortical-associated lesion with scalloped margins and perilesional sclerosis. So that indicates that the lesion is slow-growing and benign. And there's always a risk for pathological fracture when the lesions occupy more than 50% of the whole diameter of the bone. The histology of non-ossifying fibroma is that of a spindle cell proliferation with a peculiar storiform pattern, scattered osteoclast giant cells, usually clustered around areas of hemorrhage, and very bland fibroblastic or myofibroblastic appearing cells. Here we see much closer view that the nuclei are very, very bland. And you may see occasional mitosis, but usually not in a large number. I already mentioned that they may regress spontaneously, so follow-up may be adequate as treatment. The differential diagnosis will be mostly with giant cell tumor of bone, Giant cell tumors of bone usually occur in skeletally mature individuals with closed growth plates and usually involve the epiphysis, not only the metaphysis. This is actually in the metaphysis going into the diaphysis. And if there is any problems, G34W would be helpful in confirming a giant cell tumor. The treatment is curettage and bone packing or resection, depending on the dimensions of the lesion. When there is a risk for pathological fracture, it is always necessary to treat. Other than that, just follow up. Here we have a beautiful one with a storiform arrangement of bland spindle cells, giant cells, and some foamy or vacuolated histiocytes. Benign fibrous histiocytoma is histologically identical to non-ossifying fibroma. The only difference is that this lesion clinically presents at an older age and very unusual bones with a different radiographic appearance. But the histological components are the same: fibroblast-like cells, multinucleated giant cells, foam cells, and storiform pattern can be quite conspicuous. The lesions are clinically painful, even in the absence of fractures. So that's one main difference. Pain is indicative of growing lesion versus a more quiescent lesion like NOF. The ilium and the ribs are preferred sites, and in the long bones, the lesions is usually centered in the diaphysis. They can also occur in the metaphysis, but they're usually more diaphyseal. So that's another significant difference between NOF and BFH. There is a tendency for local recurrence in benign fibrous histiocytoma. The lesion is mostly seen in adult patients, which is also different from NOF. Gender distribution is similar, and the main differential diagnosis, I already mentioned NOF in how to distinguish between the two, and then with giant cell tumor, sometimes that can be a little challenging because giant cell tumor can have fibrohistiocytic looking areas. So G34W probably will be the way to solve this dilemma. The treatment and prognosis of benign fibrous histiocytoma is there is a high rate of recurrence, so complete resection is preferred to curettage. Unfortunately, a lot of these lesions are treated by curettage, and they will recur very often. This is the radiographic appearance of a benign fibrous histiocytoma. This one is occurring in the ilium, and you can see that the lesion has sort of like a perilesional sclerosis, and it's lytic, and there's evidence of cortical disruption here. So that's why they may look a little bit more aggressive than an NOF. And this is another case where the lesion is in the mid shaft of a long bone, and you can see that there's some internal trabeculations within the lesion. The appearance of benign fibrous histiocytoma, again, very similar to non-ossifying fibroma. In this particular one, we see a lot of foam cells, spindle cells, beautiful cartwheel arrangement of the spindle cells or storiform pattern, clusters of osteoclast-type giant cells closer to areas where there is hemorrhage, and hemosiderin deposition. Another fibrous lesion, which is quite rare, is the desmoplastic fibroma. It's a locally aggressive fibrous tumor that is non-metastasizing, and it's composed of bland-looking fibroblasts and myofibroblasts embedded in a very prominently collagenized stroma. So it looks almost identical to a desmoid tumor or a aggressive fibromatosis of soft tissue. And the behavior is very similar. It's locally aggressive and it has infiltrative growth. It presents usually with pain and swelling, and about 10% of the cases will be associated with a pathological fracture. Radiographically, the lesions have a bubbly or multiloculated appearance, and they will have some internal trabeculations as well. The cortex may be destroyed, and invasion into the soft tissue may occur. Desmoplastic fibroma is very common in the mandible, usually in the mental portion of the mandible, and also in the long bones, the proximal humerus, distal femur, proximal tibia, and also the iliac bones are common sites. This usually occurs in patients into the first and second decades of life, but mostly the second decade. And here we have another example where there's a lytic lesion with a very prominent internal trabeculations that are characteristic of desmoplastic fibroma. The lesion is really rare, to be honest with you. It's not very common to see this tumor. Now, the appearance of desmoplastic fibroma is identical to a desmoid tumor. It's a very well collagenized tumor with a low to moderate cellularity. You may see a vague fascicular arrangement of the spindle cells, and if you go closer, you see that there is abundant collagenous matrix, and you see that the tumor cells have this elongate appearance with blunted ends and very delicate chromatin. You may see small nucleoli and sometimes nuclear pseudo-inclusions, and at times the nuclei may have a somewhat wavy appearance. The tumor cells may be immunoreactive for beta-catenin like desmoid tumors do, but they do not carry the mutation. And the main differential diagnosis for desmoplastic fibroma, which is a very challenging differential, is low-grade fibrosarcoma. Sometimes fibrous dysplasia, especially in a biopsy, may have absence of woven bone trabeculae. So you only see the fibrostroma, but that happens very seldom. But low-grade fibrosarcoma has identical appearance, histological to desmoplastic fibroma, and may appear similar on the radiograph. And the only difference may be that there will be focal nuclear crowding. There may be a little bit increased cellularity in some areas. You may see mild to moderate nuclear atypia and increased mitotic activity in the range of 4 to 5 mitosis per 10 high power fields. Mitotic activity in desmoplastic fibroma is very low to absent. So if you see a tumor that has increased mitotic activity, you may think of reclassifying the tumor as a low-grade fibrosarcoma. This is more of academic interest because both lesions will have a similar behavior. No metastatic potential, but locally aggressive behavior with high recurrence rates. What excision is the better treatment for desmoplastic fibroma? Curettage is really not advisable because these lesions will invariably recur. Metastases have never been described. Fibrosarcoma is a very, very, very rare malignant spindle cell neoplasm that exhibits exclusively fibroblastic differentiation. There will be no matrix production, and the distribution is very similar to osteosarcoma, but it usually happens in older individuals. Most osteosarcomas do occur in children and adolescents. These tumors are more aggressive and they have a higher propensity for metastases. May present with pain, swelling, and all the associated symptoms of an aggressive intraosseous tumor. They may occur secondarily to pre-existing conditions, Paget's disease, radiation, fibrous dysplasia, and osteomyelitis, among others, and even bone infarcts. And radiographically, they appear as lytic destructive lesions with a very irregular permeative appearance. Here, you really can't see the boundaries of the lesion, but you do see that there is some evidence of bone loss. So this is like a permeative growth with eventual destruction of the cortex and invasion into the soft tissue. Fibrosarcomas are very, very rare. The reason being that most of them usually are reclassified either into a fibroblastic osteosarcoma or undifferentiated pleomorphic sarcoma. But the fibrosarcoma usually occurs in the same location as osteosarcoma, distal femur proximal tibia. They may occur in the spine and sacrum, also the pelvis, and even the mandible and proximal humerus. The distribution is usually in adult patients older than 20, 30 years of age, and almost equal gender distribution. Here we have another example of one where you can really see that there is a very ill-defined cell tumor borders, and there is a pathological fracture associated with the lesion. Grossly, these lesions appear very fleshy, masses with areas of hemorrhage and necrosis. The classic appearance of a fibrosarcoma is that of slanted intersecting fascicles, or better known as the herringbone pattern of arrangement. They're basically very hypercellular with a lot of mitotic activity. And we have to remember that this pattern is not exclusive to fibrosarcoma. It can be seen also in other tumors like malignant peripheral nerve sheath tumors and monophasic synovial sarcoma. Both of these entities are very rare in bone, but they have been described. So seeing this pattern alone does not mean that this case is a fibrosarcoma. You have to definitely exclude the possibility of this being other lesion because primary fibrosarcomas of bone are rare. And the other thing that needs to be considered is a fibroblastic osteosarcoma. So extensive sampling of the lesion is required in order to find focal areas of woven bone formation by the tumor. In which case you have to reclassify the tumor as a fibroblastic osteosarcoma. On high power view, we can see here that the cells have very hyperchromatic elongate nuclei, scant cytoplasm, and very indistinct cell borders. So this is a classic appearance of a grade 2-3 fibrosarcoma. Rare lesions will have an appearance like this one. This is a very well collagenized tumor, which is moderately cellular, not a lot of cytological atypia, but we have a couple of mitosis in one field. So this is a low-grade fibrosarcoma, almost histologically indistinguishable from a desmoplastic fibroma, except for the presence of readily identifiable mitotic activity. So take that into consideration. If you have a lesion that looks like that, but has mitotic activity that is easy to find, consider that it might be a low-grade fibrosarcoma. Histological grading is valuable in predicting the behavior of the tumor. Grade 1 lesions usually have about 1 to 4 mitosis percent high power fields and have an excellent survival, 10-year survival rate, almost 83%, with very rare or no metastasis at all. Versus grade 2 tumors, which have moderate pleomorphism, many mitosis, and less collagen, and grade 3 lesions, which actually, if they do show evidence of pleomorphism and nuclear anaplasia, they may probably will be classified as an undifferentiated pleomorphic sarcoma. So high-grade tumors will have a much worse survival rate. Tumor treatment is white resection or amputation, depending on the extent. And metastasis to lungs and other bones occurs in high-grade lesions. Radiation and chemotherapy may improve survival. Finally, we're going to mention undifferentiated pleomorphic sarcoma, ex-malignant fibrous histiocytoma. So now, because originally these tumors were thought to have some degree of histiocytic or fibrohistiocytic lineage, they used to be called MFH, but this is now disfavored. It is better to call them, because they basically have no specific line of differentiation. Now the preferred term is UPS, undifferentiated pleomorphic sarcoma. The cells are usually very anaplastic looking. They vary from spindle to epithelioid, and many times multinucleated and gigantic. And these comprises about 1% of bone malignant neoplasms, and may be secondary, again, to post-radiation or to radiation bone-infarct Paget's disease, and even may be seen as the dedifferentiated component or the pattern of the dedifferentiated component of other tumors like dedifferentiated chondrosarcoma or dedifferentiated low-grade osteosarcoma. Pain and mass effect are the most common manifestations of undifferentiated pleomorphic sarcoma, and radiographically it may look identical to a fibrosarcoma. Ill-defined permeative lesion with cortical destruction, soft tissue extension. Pathological fracture may be seen very commonly, and they really have nothing specific genetically. Their complex structural and numerical chromosomal aberrations are common, similar to osteosarcoma and chondrosarcoma. Metastasis to lungs occur very often, much more often than other tumors. They may involve proximal femur, distal femur, pelvis, proximal humerus, proximal tibia. They may occur even rarely in the spine. And here we have another example where we have a tumor that has a very ill-defined margins, but it definitely has destroyed the anterior cortex and invaded into the soft tissue. This is not necessarily the same case, but the gross specimen of a resection of a distal femur differentiated promorphic sarcoma, where the tumor has this very fleshy tan yellow appearance with areas of necrosis and hemorrhage. This is a tumor that is more commonly seen in patients older than 40, but we have seen it at an earlier age. It is important to rule out the presence of woven bone formation within the tumor, in which case the tumor needs to be reclassified as a high-grade osteosarcoma. You may find bone formation focally in UPS, but it's usually of metaplastic characteristics. So it may have a somewhat trabecular appearance and not really be the lace-like pattern of woven bone formation that you characteristically see in an osteosarcoma. UPS, at least focally, will show storiform arrangement of the spindle cells. That will be radial arrangement of the spindle cells, and you may see scattered anaplastic-looking cells with very hyperchromatic nuclei, which may appear very bizarre, and you may see a lot of mitotic activity, including atypical forms. The main differential, actually, on differentiated promorphic sarcoma is a diagnosis of exclusion. So you need to make sure that this tumor shows no line of differentiation. I usually perform a very broad panel of immunohistochemical markers, making sure that this is not a pleomorphic anything, because you may see tumors with similar morphology that may be, I would say, pleomorphic leiomyosarcoma, pleomorphic rhabdomyosarcoma, which are the main ones that we want to distinguish. Pleomorphic liposarcoma would probably be unlikely because usually you do see lipoblast around it, but sometimes there may be entrapped fat within the lesion that may throw you off. But mainly, smooth muscle actin, desmin, myogenin should be negative in these tumors. Most of the times, at least you will see positivity for vimentin. You may see focal and weak positivity for actin. You may see CD68 positivity. So I have seen tumors with CD34 positivity, usually not diffuse, but everything is really non-specific. And watch out, they may be positive for epithelial markers like keratin, in which case the diagnosis of sarcomatoid carcinoma has to be excluded. Fibrosarcoma would also enter the differential diagnosis, but only from the radiographic standpoint. This degree of pleomorphism is definitely characteristic of undifferentiated pleomorphic sarcoma. The treatment is with surgery and adjuvant chemo, actually neoadjuvant chemo. So I have been receiving consults from outside on patients that have been treated with neoadjuvant chemo with variable degrees of response. So tumor mapping, similar to osteosarcoma and Ewing sarcoma, can be performed, and large clinical trials are necessary to see if the 90% threshold of tumor response has similar prognostic impact on the survival of these patients. If the patient is treated with surgery alone, the mortality is, the survival is only about 18%, so the mortality is pretty high. So with this, I think we're going to conclude. Fortunately, there was not enough time to keep covering many other tumors that do occur in the bone, including tumors of all the mesenchymal lineages like leiomyosarcoma, rhabdomyosarcoma, lipomas, rarely liposarcomas, and most importantly, vascular tumors of bone. So perhaps there will be an opportunity for that in the future. Thank you very much for having me in this platform, and now I open the podium for questions.
Thank you, Dr. Garcia, for this excellent talk on miscellaneous tumors of the bone. And of course, we would be more than happy to host you to cover the remaining topics. I have a few questions that I see online. So one question is from Dr. Ambarish Pradhan. The question is, how frequent is peripheral adamantinoma? And what is the cell of origin of this tumor?
I believe that you refer to peripheral because they occur in appendicular skeleton and not on the gnathic bones, because they have adamantinomas and amyloblastomas have been somewhat linked. But because normally when we refer to a peripheral, is a tumor that occurs outside of the medullary cavity. But adamantinomas are, to be honest, not very common. We don't see them that often in clinical practice. And the cell of origin of adamantinoma is not very clearly established because the characteristic morphological appearance and immunohistochemical profile is that of a basaloid tendency to like a squamous epithelial-like type of tumor. That type of cell, they're considered to, and because of the proximity to the skin in the shin, which is when most of these tumors occur, they have been thought to be probably due to entrapped remnants of basaloid epithelium from the skin during embryonic development, but that is really just a theory. We now know that a lot of tumors, basically, we don't have to see them as what is the cell of origin, but more of what is the line of differentiation of the cell. There are pluripotential mesenchymal stem cells everywhere in the body, but mostly in the marrow, that can go in any direction. And we know that the same cells that gives rise to the osteoblast, gives rise to the chondroblast, to the myocyte, to the adipocyte, and to the stromal cell of the marrow. Just think about pluripotential mesenchymal cell that took a hit and started differentiating into epithelial lineage, and not what cell exactly gave rise to this tumor. That's how you explain, for example, how does a rhabdomyosarcoma arise in the medullary cavity of a bone where there is no skeletal muscle whatsoever. So think about it as the line of differentiation or direction of differentiation, and not as where it came from.
Right. The next question is also from him, that what is your experience about fine needle aspiration of bone tumors? Because he gets some request for such procedure.
Well, I have to say that it's limited. We do not perform FNAs in our institution or none of the previous institutions where I used to work. I know that it's a very broad field, and there's a lot of experience in other centers with FNAs of bone lesions. But to be honest with you, we don't have a lot of experience on that. There is a large limitation, I think, on pattern recognition, because all you see is just the cells by themselves. And I suppose that you will need a lot of clinical radiological correlation in order to establish the diagnosis. So yeah, my experience is very limited on that.
Right. The next question is from Celestine. So the question is, when will you call a tumor a grade 3 fibrosarcoma versus an undifferentiated pleomorphic sarcoma? Because essentially both would be a diagnosis of exclusion, and no immunos will probably help.
I have to say that I would, if a tumor shows a high grade morphology, including high mitotic activity, extensive necrosis, and most important of all, pleomorphism, I would jump immediately into the undifferentiated pleomorphic sarcoma. If you look at it from an objective perspective, a UPS or an MFH is a grade 4 fibrosarcoma. It's the ultimate pleomorphic anaplastic high-grade tumor. The only difference probably will be the presence of storiform pattern, at least focally. and I think clinically it makes no difference. A grade 3 fibrosarcoma and a undifferentiated pleomorphic sarcoma probably will have similar prognosis, behavior, and require the same treatment. So again, fibrosarcomas are so rare that you probably will feel comfortable calling something fibrosarcoma if you saw something like a grade 2 with a very monotonous spindle cells arranged in your classic herringbone arrangement, or if you have something looking like a low grade that has the appearance of a desmoplastic fibroma with mitotic activity. But if you have something that has significant amount of pleomorphism, you probably will push it into the category of undifferentiated pleomorphic sarcoma.
Mines has this question for you. What other sarcomas can give BCOR positivity in your experience? And how would you differentiate BCOR sarcoma from a synovial sarcoma?
Okay. I'm not sure about what other sarcomas can be BCOR. The only experience I have with BCOR is with these round cell tumors, or the Ewing sarcoma-like components. And the second question was, can you repeat the second question, please?
So how to differentiate BCOR sarcoma from synovial sarcoma?
Oh, well, definitely by finding positivity for epithelial markers. That would be the first one. I think that one feature of synovial sarcoma that is extremely helpful, at least for me, is the presence of staghorn-like vascular spaces, like hemangioperocytoma-like areas. I definitely will not rely on TLE1 because, as you know, it can be consistently positive in BCORs. So finding positivity for keratin is one, and of course you would have to resort to your mutational analysis. Synovial sarcomas have very exclusive gene rearrangement, which is rearrangement of SS18 or your X18 translocation. So I would say probably from the primary workup will be the positivity for keratin. Even though we know that BCOR has a very kind of like broad immunohistochemical profile, very variable and non-specific. But definitely do not trust DLE1. You have to go for your keratins and then next move on to mutational analysis. Rule out SS18 rearrangement.
The next question is from Antoy, who is from South Africa. The question is also on similar line, that can you stain BCOR-rearranged Ewing-like tumor with cyclin D1? And why is that in high-grade endometrial stromal sarcoma that are BCOR-rearranged, one can use cyclin D1? So what is your experience on that?
Well, to be honest with you, I don't see endometrial stromal sarcomas. Because I'm in a very specialized center, so usually those go to a separate department in other locations. We see exclusively musculoskeletal tumors. So cyclin D1 again is also positive and is totally non-specific. So yeah, definitely can be found, but it's not really of diagnostic utility.
The next question is from Terence. So in adamantinoma-looking lesions of the head and neck, do you rule out adamantinoma-like Ewing sarcoma by doing a CD99?
Well, it only if you have the classic histomorphology. CD99 does not help you. Remember, it is totally non-specific. It can be seen in a lot of tumors. So I will definitely go straight for the EWSR1 rearrangement. That is what definitively tells you that this, by the way, we didn't discuss that, but an adamantinoma-like Ewing sarcoma is a tumor of round blue cells that is diffusely and strongly positive for keratins. And that in that particular instance, it may enter the differential diagnosis of a poorly differentiated carcinoma. But CV99 positivity will probably trigger the testing for EWSR1. But CV99 has been described in so many other tumors that are not Ewing sarcoma that it totally will go and rely only on the EWSR1 gene rearrangement.
The next question is from Suma, who thanks you for the lecture and also wants to know what is your experience on tumor necrosis in Ewing sarcoma. That means that how much percentage of cases might be showing more than 90% tumor necrosis?
I have to say that quite a few. It looks like most of the classic Ewing sarcomas have a very good response to the specific protocol that they're submitted to. So the combination of drugs that they use is pretty effective. And from the top of my head, I would say that more than 80% of the cases that I have seen have more than 90%, if not more than 95% tumor necrosis. So in spite of how aggressive these tumors are, it looks like they do respond very well to chemotherapeutic regimen protocols. So that's probably from the top of my head, more than 80% of them have an excellent response.
And one last question that's also from her. So who wants to know, is there any histologic features that favor good response in Ewing sarcoma, I'm sure?
Not that I know of. I mean, the only thing that we rely on is complete disappearance of the nuclei. Like the picture that I showed you during the lecture, what you see is just basically hyalinization and sclerosis of the stroma, or fibrosis of the stroma, many times just myxoid change and scattered inflammatory cells. And if anything, you may see some occasional surviving cells here and there that look so distorted that the likelihood of those being viable is low. So yeah, but there are no other histological parameters that I could really recall that are used for impacting prognosis.
Thank you, Dr. Garcia. I think with that, we have come to the end of this question answer session. And thanks again for your excellent talk, Dr. Garcia. And I'm sure that the last 3 lectures on neoplastic bone pathology will be really very helpful to everyone, and especially those who are preparing for pathology boards. These are really excellent resources. And we would be more than happy to welcome you back in future. And Dr. Garcia, you would be so glad to know that you had several hundred viewers from at least 30 countries that I could keep track of, including Clemencia, who tuned in from Dominican Republic. And they all defied time zone and listened to the lectures. And thanks to our viewers for your support. And if you like our lectures, so please remember to follow our Facebook page and also subscribe to our YouTube channel so that you can stay updated. And also please subscribe to our newsletter. That will also keep you informed about all the upcoming lectures. And we actually have our next podcast coming up. That's on Tuesday, that is July 14th. We have 2 lectures on July 14th. One is at 8 a.m. Eastern time. That would be on liver pathology, regression of fibrosis in chronic liver disease by Dr. Neil Thies from New York. And at 12 p.m. Eastern time, we will have a lecture on microbiology that would be on mycology, in which Dr. Marky Morgan from Cedars-Sinai Hospital will talk about introduction to dimorphic fungi. Hope to see you all soon, and thank you again. Thank you, Dr. Garcia.